All right, excellent. Now over to yourself, Jonny.
Okay, thanks very much, Lucas. So I'm Jonny Acheson. I'm an emergency medicine consultant in Leicester. I'm also, as Lucas said, the RCEM QUIP time critical medication lead. So I thought what I would do, first of all, is just give you a bit of background to year one of the QUIP. So the QUIP is running for 3 years. It started in November 23 until November 24 for year one. Year two is running from January 25 to December 25, and then year three is running from January 26 to December 26. So year one's complete. We're halfway through year two. So year one, really, we were hoping departments would focus on early identification of people who present the EDs on time critical medication. The focus of year two is really this subject about self-administration when they come to an emergency department, and it's quite a hard nut to crack, and that's why we've organised this webinar to get some discussion today. So if you just move on to the next slide, Lucas, that'd be great. So let me ask you this question. So this was from a report back in December last year from the Health Services Safety Investigations Body, and it's simply this. How can an 85-year-old man walk into an ED, self-administer a dose of levodopa at 8 o'clock at night, spend 52 hours in the ED, 44 of those hours were in the corridor, not be given 10 out of a further 18 doses of levodopa that he needed? He aspirated when he reached the ward and he died 4 weeks later. And the coroner's report basically said that one of the contributing factors to his death was the fact that he didn't get his time critical medication when he needed it, when he was in the emergency department and in the corridor. And the question I want to ask you this morning, as you sit and think about this, is honestly, if you're sitting here this morning, do you think that that could happen in your own hospital today? I don't know whether you've got people in corridors waiting to go to the ward. I don't know how long they stay on the wards for. I don't know what your setup is between the interaction between ED and the admitting teams, but just have a think. Could that happen in your hospital today? So moving on to the next slide. We have three standards in the QUIP. So as I said, in year one, we were really concentrating on getting patients identified to see whether they were on a time critical medication whenever they arrived at the emergency department. And that was for within 30 minutes of arrival, because people with Parkinson's don't present with Parkinson's. They present as a complication of or not related to it at all. And it's the same with people on insulin. So nationally, what the year one QUIP showed that 46%, 46.6% of people who are on levodopa orally and subcutaneous insulin who were suitable for the QUIP were identified within 30 minutes of arrival. And that was much better for people on levodopa than it was for people on subcutaneous insulin. In our own department, we discovered that although we identified people were diabetic, we didn't actually identify whether they were taking insulin or not. So that was a change we had to make. So that was standard one. Standard two then looked at the percentage of time critical medication that was administered within 30 minutes of the expected time. And again, we didn't do so well on that. So nationally, levodopa combined with subcutaneous insulin was 34.1% of people got their time critical medication within 30 minutes of when they were expecting to get it within emergency departments. Again, levodopa did better than insulin. Insulin was about 19%, so levodopa was about 42. So, and that's probably as a result of the campaigns that have been going on from Parkinson's UK over the past X number of years. So that really made us question, out of those doses, how many people did actually self-administer? So if you look at the next slide, you will see that nationally, levodopa self-administration was 11.2%. So out of everybody that was suitable to be included, 11% roughly of people self-administered. But interestingly, even when they self-administered, they didn't give it within half an hour or 100% of the time. when the patients themselves were given their own medication, self-administering it, they still only did it 74% of the time. So if we look at insulin, you'll see that the figure was similar. On the next slide, I think it was 10.2% self-administered, and 53% gave it within 30 minutes of when we thought they were getting it. Now, that data, for instance, might be slightly skewed by the fact that if a patient hadn't eaten or their food was delayed, then they wouldn't have taken their insulin when they were due to have it. So we didn't have the data for what time they ate at, but the insulin data that we were really interested in was really the missed doses. So I suppose 10% self-administration of suitable patients within year one of the QIP. If you go on the next slide, Lucas. So we wanted to know, was there anywhere in the world that that does self-administer, allow patients to self-administer their time-critical medication? This was an article that came out last week about a emergency department in Canada, and that basically directed people with Parkinson's, suitable patients with Parkinson's, to be able to take their medications in the department. Now, I contacted them because it was unclear whether this was just in the ED waiting room when they were waiting to come into the department, or whether it was all patients who were deemed suitable to self-administer their time critical medication who potentially walked in. So it has been done. Certainly in this case, it was for people in the waiting room for sure. I don't know whether they were able to transfer that across to patients in the main department, but I'll let you know when I find out. So if you go on the next slide, Lucas. So what I want you to do now, if you can, on the screen is the QUIP team at RCEM, along with the UKCPA and the Clinical Pharmacist Association and the Association of Ambulance Chief Executives, got together and we wrote a document called it was an RCEM advisory statement on time critical medication self-administration in emergency departments. So if you get your phone, I'll do it in real time as well. So if you get your phone and just scan that QR code, you'll be able to pull the document up. And I don't know if you've ever tried to write a document like this, but it actually takes a long time to get the wording right. And when you've two other organizations involved, three in total, there is a bit of to and fro to get the wording correct. Now, what we were keen to do was, obviously, I don't know what trust you work in, but most trusts will have a medicines management team and have a self-administration policy for their hospital. The difficulty with the self-administration policy for the wards is that it isn't fit for purpose for the emergency department, because the emergency department is a different kettle of fish and there's different challenges and there are different risks. But it still needs to come under a governance structure. So what we decided to do, we decided to come up with 4 principles that could potentially be applied by trusts, emergency departments, and potentially these principles could then be developed locally in EDs and then form part of an addendum to your trust's self-administration medicines policy. So the acronym for that nationally is SAM, so SAM, self-administration of medicines. So if we go on the next slide. So we came up with four principles, and our sort of mnemonic is SAM with 2 A's, so it's SAAM. And the first thing that we came up with was that if somebody pitches up to an emergency department who's on time critical medication, so we looked at in the QUIP, we're just looking at oral levodopa in Parkinson's and subcutaneous insulin in insulin treated diabetics. And the first thing that we came up with was the patient should be able to show the staff what time critical medication they're on. So if a patient pitches up and they have the definition of a time critical medication is a medication that they're already on. It's a maintenance dose. So it's not an emergency drug. It's not a stat dose. It's a maintenance drug that they need to take at a certain time. The 2 that we are looking at need to be given within 30 minutes of when they're usually taken. So people who pitch up to the emergency department should have their medication on them. And that's the first principle. So somebody who's an insulin-dependent diabetic who doesn't need escalation in their treatment should be able to self-administer their insulin subcut if they're deemed suitable to do so. Patients who have Parkinson's who don't need a patch should be assessed to see if they can take their own time-critical medication. But the first principle is they need to have it on them, and they need to be able to show you what they're on. So that's the first point. The second principle then is after they've been able to show you what they're on, you need to be able to carry out some sort of assessment. And this is the meat of this will be in the next part of the talk. So EDs have to undertake some sort of assessment to determine which patients are suitable to self-administer their own medication. And we can talk about that later on, but there needs to be some sort of assessment. After assess, then you should be able to make a decision then to either allow the patient to take their medication. If the patient can show you their medication, if they, after assessment, they're deemed suitable to self-administer their time-critical medication in the ED, then they should be allowed to do that if they're happy, and it should be documented appropriately. If a patient is unable to show you their time-critical medication, or they can show you, but they're deemed unable to self-administer after the assessment's been undertaken in the ED, then staff should aid that patient's medication to be given following clinical review and prescribing of the time-critical medication. And then the last letter to complete the SAM is sorry, I thought I lost you there. The last principle is that this should be monitored. So we weren't going to put this in, but the college were quite keen that as this is potentially a new thing for EDs, that we wanted to monitor the process. So if patients are self-administering, then it needs to be documented, either written or electronically, that the patient is taking their own time-critical medication. And the reason for that is, I think, you know, just to as it beds in, it really puts the ball in the patient's court. So if I was sitting in an ED needing to take my own Parkinson's medication at 8 o'clock at night, I would be able to, you know, potentially show my medication, get my assessment done, I'm deemed capable of taking them. I would then ring my buzzer at 8 o'clock and say, I'm going to take my meds now. The nurse would come in, watch me do it, and then document it on emails that I've done that. And that's what we do in our department. And it really puts the emphasis on the patient, and the nurse doesn't necessarily need to be reminded of it. It should pop up on their iPad that it's due. So it's a mutual two-way street. So that's the principle. So show, assess, aid, allow, aid, and monitor. And that's basically for the purpose of the QIP. It's as I said, oral levodopa and subcutaneous insulin. But if you move on to the next slide, you'll see that the college I'll talk about that in a minute. But if we can somehow, so 10% of patients in year one of the QIP administer their time-critical medication themselves. If we could even increase it up to 20% in year 2 or year 3, that's going to have a massive impact on the percentage of doses given within 30 minutes of when they're expected to be taken. We're not under any illusions that this is going to go up to 50% or 60% just with the patient cohort that are coming in. But if we can get it up to 25%, 30% even, you know, potentially there's a lot of time to be saved and a lot of paperwork potentially to be saved, but it has to be done in a safe way. And the question is, that's why we're here today. How do we actually do that? The paperwork that's done in the ward isn't fit for purpose in the ED. It's too much. It's a different environment. So if we go on the next slide, you'll see that although we are concentrating on obviously Parkinson's medication and insulin, this was the list from the college about which, in their view, medications are time critical, and it uses a missed mnemonic, so movement disorders, Parkinson's, myasthenia gravis, I, immunomodulators, including HIV, S is sugar, so insulin, steroids for Addison's and adrenal insufficiency, E's epilepsy, and D's DOACs, and warfarin. And we're trying to get that message out there that says the strapline, if Lucas just hit the button, it says that a missed time critical medication dose causes harm, and it does. So year 3 of the QIP, although we'll still be looking at Parkinson's and insulin, we're encouraging departments to look at all these as far as time critical medication goes, and as far as self-administration potentially goes. So I'll just hand over to Kunal now, who's going to take us through the next section.
Thanks very much, Jonny. Appreciate it. So my name's Kunal. So I'm a specialist clinical pharmacist. I work in Nottingham University Hospital's Queen's Medical Centre, so RA&E here. Been doing it for about 10 years. We're quite a long way into our journey around time critical medications management. And so we're in the process of adapting this advisory statement as well. Obviously, it came out a little while ago. We're still going through our governance processes. So we completely acknowledge that it's not an easy advisory statement to adapt directly without local risk assessments. But the important thing is that we've got the right considerations and looking at the right prerequisite challenges around medications to be able to get a good pragmatic policy. So the key thing that I'm going to focus on my part here, your considerations around how you'd risk assess particular patient presentations, particular time critical medications, and how you do that pragmatically for the emergency department. Exactly how Jonny mentioned, that the emergency department and the wards, completely different ball game with completely different challenges and a completely different environment. So any kind of procedure SOP you develop will need to be directly targeted to the ED. We'd be looking to make sure that procedure or that process maximizes efficiency for the ED, for ED staff, and obviously minimizing any risk of patient safety issues or any kind of risk to patients as well. And part of it as well is we'll look at the prerequisite processes that you might well need to adapt before you can even look at self-administration. That's around identification, that's around encouraging patients to bring their medications in, and general improvement strategies as well. All right. If we have the next slide, Lucas. So in terms of general benefits, Jonny's touched on it. We know from some of the data, the key things around allowing self-administration with secondary care, there's patient experience benefits. So there's empowerment for patients to be able to take responsibility of their care. Patients typically will have a better experience and be more involved and have more, ownership of their treatment if they're maintaining responsibility and control of their care, which is facilitated to a certain extent by self-administering prerequisite medications. We know from the data as well that self-administration where patients have access to their medications, it's associated with them therefore getting their medications more on time, which is sort of relayed from the data that Jonny presented. And we know that theoretically, we're introducing an efficiency benefit for ED clinical staff, giving the responsibility of the patients to maintain their administration, both for nursing and clinicians. So we know there's benefits here. So this is a worthwhile exercise. For the next slide, Lucas. That being said, we know in the emergency department, given the chaotic environment it can be and the undifferentiated nature of patients that are attending, we may have particular time critical medications, even though we know they can cause harm when emitted. Given the scenario of their presentation, they might well be contraindicated given the situation. There may well be situations where patients attend with their own medication, but their medications aren't fit for purpose. They're expired, they haven't been stored appropriately. They may even be a reason that the person has attended in relation to an adverse drug reaction. We have risks around allowing self-administration with poor communication or documentation, which may increase the risk of duplication of therapies, where a patient may have self-administered, we then haven't communicated that properly, and we administer a dose in a traditional prescribe administer fashion, which could potentially lead to an overdose. And we have problems with patients who might have fluctuant memory issues within the department. So an initial assessment of suitability for self-administration may change down the line depending on the scenario of the patient. So we have clinical challenges and potential patient safety risks which need to be considered. We have the next slide, Lucas. The first thing we need to consider around self-administration in the context of ED is, do patients have their medications with them? Now, self-administration policies within hospital wards typically have procedures involved that allow supply of those medications to the patient, which are labeled understanding their, assessing their understanding, and then allowing them to administer supplies that they've been physically given by the hospital. Now, that's less of a useful situation for EDs. You're effectively at that point having to confirm a drug history, have the risk of prescribing it, getting it to them, and then monitoring them. That's a very inefficient process in terms of getting them medications. So realistically, most patients that you're going to be targeting for self-administration within ED are going to be involved in patients who have their medications with them. Strategies to potentially improve patients attending their EDs with these medications to allow you people that are going to self-administer. In terms of your patients who walk in, we're looking to make sure that we've got clear expectations around patients, what their waiting times are. They can then make decisions around if they need to get access to their medications or have them brought in. And in terms of our ambulance crews, so handovers between ambulance crews, strategic messaging with ambulance crews to make sure that they're prompting patients to make sure they have their medications brought in on the ambulance with them or obtaining them. That's work that we're doing centrally through the QUIP group with the AACE. But there's potentially room for central local communications with your regional centres and your local ambulance crews around facilitating that as well. So we need to make sure that we're facilitating people bringing their medications in wherever possible. We have the next slide, Lucas. We're then looking at more of a general concept of patients who might be suitable for self-administration. Now, we know that we have a lot of patients who may not directly supervise their own medications at home. They may require carers. They may require relatives who manage their medications for them. We may have people that come in with acute illness or injury that doesn't allow them to self-care at baseline. They're off their baseline in terms of being able to self-care, meaning self-administration is going to be less suitable for them. Obviously, we talked about patients who don't necessarily have their medications with them. And then we may have mental health or overdose type situations or presentations where it may not be appropriate to leave those medications or allow them to self-administer because they have had an acute problem with their previous, with their normal medication regime that has led to their presenting complaints. So it's less appropriate for these people potentially to self-administer. Our more suitable patients tend to be people who have direct responsibility and understand their medication regime. They know what they're taking, they know when they're taking it, they know why they're taking it. People that have access to their medications obviously with them, and they're self-caring at baseline. So they have the ability to self-care at their baseline in the context of their presenting complaint. So here we need to make a decision. Are they self-caring? Do they have capacity, and do they understand what their medication regime is as a prerequisite for self-administration? All right. Next slide, please, Lucas. Based on those particular presenting complaints. Now, we know in ED we deal with undifferentiated patients, one of the unique environments that have true undifferentiated patients, where medical problem, surgical problem, all sorts of problems that are potentially involved. And potentially we're going to be needing investigations to get to an underlying diagnosis. Now, we know that some time-critical medications, as I alluded to previously, may have contraindications depending on what the acute presenting complaint is. There are some that have relatively few contraindications: Parkinson's therapies, anti-epileptic therapies, immunomodulators, medication for particular neurological conditions. Relatively few acute contraindications for those. You're going to continue them in most circumstances. However, there are groups of time-critical meds that may have more contraindications. So patients who are anticoagulated, depending on the indication for their anticoagulants. If they come in with traumatic presentations with suspected signs of bleeding, we may need to look at, even if they have capacity to self-administer, whether it's appropriate for them to self-administer before a true clinician assessment. We talked about insulins, and we know type 1 diabetes, again, long-acting insulin in particular, there's relatively few contraindications. However, maybe with the short-acting insulins for people that attend with hypoglycemic presentations, or maybe even abdominal pain situations or situations where they're not eating and drinking at baseline, they may not be able to self-administer due to a clinical concern. And also we may have people on particular immunomodulators who come in with infective signs or sepsis, where we may not want them to acutely administer their immunomodulators. Again, it's a risk-by-risk, case-by-case basis where we're individualizing the risk assessment. If we have the animation, Lucas. And so in these contexts, there's important at some point within your procedures, there's a dynamic risk-benefit assessment around the clinical circumstances of their presentation and whether self-administration is appropriate at that point. And as we've mentioned there, we've talked, some have relatively few contraindications and some have relatively a high contraindication risk depending on the presenting complaint. We have the next slide, Lucas. One of the prerequisites we need to look at is how we're going to identify patients who are self-administered, who are on time-critical medications. This is a journey we've been through within our ED, and a lot of other EDs are looking at this. And one might say that this is an important prerequisite before you can roll out self-administration. Do you have a realistic way you can identify patients who are taking time-critical medications, whether they're in the waiting area or whether they're in the or whether they've been handed over by the ambulance? If we have the first couple of animations, we can have two effective ways that we're doing this. Patient-led identification. So if we have the next slide, the key way that trusts have been able to find this is your patients who are well aware of their time-critical medication regime. They're able to communicate that they're critical, and they're able to escalate if there's a problem relating to that. But ways that we can further improve that is by signage in our waiting rooms or signage within our waiting areas or handover areas. And we can ensure that we have prompted questioning at the point of booking in, at the point of handover. Is there clear questioning around, do you take a time-critical medication? Have you got access to it? And then that's going to be able to prompt the potential discussion around self-administration. These are very good situations where patients can give you this information, where they may be quite suitable for self-administration. We then have more ED-led identification, where patients aren't going to necessarily volunteer that information for you. Prompted questioning between ED clinicians and the ambulance crews. We're going to have embedded and routine access to primary care records. So that might be SCR or System 1 or different records that have access to patients' regular medications. Going to be able to physically look at patients' regular medications, and we're going to utilize any pre-existing electronic flags that patients might have on them, Parkinson's disease flags, desmopressin, myasthenia, type 1 diabetes. In these situations, you might have patients that are not able to communicate this to you, which may increase the risk that they're not necessarily self-caring at baseline, or they may have an acute problem. And in these situations, you may find patients that are suitable for self-administration, but they may be more appropriate for your more traditional escalation to a clinician for prescribing and taking on the time-critical medication prescribing and administration within ED. So very important to identify and communicate your patients who are on time-critical medications in the ED. For the next slide, Lucas. Documentation, which Jonny obviously mentioned, was a very key point we had within the Royal College. So patients are taking their time-critical medications. How do we communicate that? How do we document that so that we're making sure that that's not going to contraindicate a procedure down the line? Are they anticoagulated? Have they taken an anticoagulant? They're going to need a surgical procedure. Is it clearly documented? Do we need to take that on board and administer that for them? So documentation becomes very important. So if we have the first couple of animations, the key way that we're breaking this down in terms of documentation is pre-clinician review. Is this a patient who's waiting for their full clerking and waiting for their investigation plan in ED? If so, we're looking at, do they have access to their own medications? Is there the ability within your specific ED at that point in time to escalate to a prescriber around formally prescribing that? So ideally, documentation around this should be done on a normal drug chart or on an EPMA system, because that's the most clear way of communicating. That may not be appropriate if you haven't got easy escalation to a prescriber, given that you typically need a prescriber to physically write that and sign it. How are we going to witness the self-administration to appropriate record, particularly if they're in a waiting room? Is the patient going to be asked to report to a particular nurse, back to the reception to say, I've administered this drug, can you please sign it off? Are they going to be able to review the physical medications, as Jonny mentioned there, around showing and making sure the medications are fit for purpose? We're also looking at how long is it in that interim period until they're going to get a review by a clinician. So is that going to be 2 hours? Is it going to be 4 hours? Is it going to be 8 hours? And that's going to change the risk benefit of allowing self-administration and the amount of effort that you're going to need to put into this. If you're in a situation where this is post-clinician review, so this is where the clinician now has taken some clinical responsibility for what the patient has attended for with an investigation plan. If we have the next animation, Lucas. One needs to consider, is that clinician a prescriber or a non-prescriber? So we know in EDs we have enhanced nurse practitioners who may not be independent prescribers, and your local governance procedures might mean that they're not able to prescribe time-critical medications from their past medical history. We're going to have the consideration of, is there a clinical reason to hold these time-critical medications, or can they be continued? And at that point, if a clinician could do it, we can also consider what we call safe omission. So in this case, a time-critical med, which we know may cause harm with omission, but given the circumstance of the diagnostic situation, may be safe to admit until we have further information. That's easier to do typically with a post-clinician review than a pre-clinician review. And the documentation, post-clinician and pre-clinician, post-clinician, it's easier to get it onto a drug chart and an EPMA system. Pre-clinician review, we may need to use more bespoke ways of documenting that, which may include free text fields or specific fields around self-administration pre-clinician that nursing staff may have control over. That's something that we're looking at in our trust at the moment. If we have the next slide, Lucas. And then lastly, one of the big factors, and I've had lots and lots of discussion around this with our colleagues around pharmacists within ED, is around the storage and security of medications. If you're allowing self-administration, and even if you're not allowing self-administration, given you've got a person who may not be able to self-care, what are we physically doing with those medications within ED? Self-administration within the ward, almost all situations, you'll still need to provide secure storage of the medications and giving the patient access to storing them securely. In ED is, I often say to juniors that come and see us, ED is actually not one department, it's about 4 or 5 smaller departments under an umbrella. So we have areas that are considered as a traditional outpatient area, our minor injuries area, our ambulatory type areas, which actually focus much more, they operate much more almost like a GP primary care led type service. And in that case, most trusts around outpatient areas would allow patients to maintain medications as their own property, and they maintain responsibility for them. But we also have areas within ED which are much more consistent with inpatient care around our resus areas or our higher priority majors areas, where there's lots of patients, people may be disorientated, there's lots of medications around. It may be less suitable to allow patients to maintain possession because we can't secure the custody chain, and there's risks associated with it as well. So if we have the next slide, Lucas. So when we're considering removing medications to save custody, situations of overdose or intentional self-harm, patients who lack capacity, confusion or delirium, particularly where there's the hyperactive delirium, where they're doing things, where they may be administering medications inappropriately. We may need to consider particular desirable medications, so controlled drugs that have the risk of diversion, therapeutic misadventure, which is similar to overdose, or patients that are just generally unable to maintain direct supervision of their personal belongings. So it may be people that we're giving procedures to, or we're sending them for imaging where we may not be able to easily transfer their personal belongings with them and they're unattended. In that case, we need to risk assess for removing them to a safe place. The challenges, obviously, within ED around safe custody. We've already talked about the different environments within ED, the potential that patients are going to move from one environment to another environment, which will change that risk assessment. What are your specific storage ability within your ED in those areas? Do you have access to drug cupboards? Do you have access to bespoke specific patient storage areas within their bed spaces, but then patients move? We need to be able to maintain documentation, who's taken custody. And we really have to consider a massive risk of, if we're taking these medications from people, are we able to reunite them with the patients? It's a massive problem that is massively under considered within ED. If you remove medications for them for the best will of the world because you're worried about self-harm or their lack capacity, are you going to be able to get them back to that patient? Because if you're not able to get them back to that patient, you risk harm in the medium to longer term. They're discharged from ED without their medications, which may be critical. That leads to another attendance. That's happened to us. You've not transferred those medications to the ward, which means they don't have access to time-critical medications, which can cause delays. So if we have the next animation there, Lucas, it's very, very important to consider the risk of loss of medications and failure when considering your risk assessments about removing medications from people. And we need to obviously have very focused local risk assessments based on what your capacity is as your local ED around self-administration and around what your storage particulars are. We have the next slide, Lucas. And so there were some whistle stop, but some considerations that we need to think about. I'll hand over to Jen, who'll talk you a little bit more about the resources available.
Thanks, Kunal. That was really good. Thank you so much. Hi, everyone. I'm Jen. So I am an advanced specialist pharmacist for medication safety at the Specialist Pharmacy Service. If you haven't heard of Specialist Pharmacy Service, or SPS, we are a service that's commissioned by NHS England. And I also work as a governance and safety pharmacist at an acute hospital trust as well. Next slide, please, Lucas. So as Kunal alluded to, I'm going to give you like a really quick tour of some of the resources that might be useful for you and will be able to complement hopefully what you've learned today. Just a few caveats though. So a lot of the resources that are available online won't be specifically aimed at the emergency department. So please do keep this in mind when you are reading them. It's important that you obviously use the information, but use it where it's appropriate and where it's actually applicable to your environment. And unfortunately, there is no one-size-fits-all approach, which I'm sure you've probably all gathered by now. Self-administration is complex. It's really hard to implement, but as we've talked about, it's really important as well. So this is why things like this are really important, so we can share learning and hopefully all get there together. Next slide, please. So the first set of resources are produced by SPS, one of the people that I work for. So we have a whole suite of resources on self-administration of medicines on our internet pages. I've put the URL at the bottom there, and I'm hoping someone will either put it in the chat or I will put it in there later. As I mentioned, it's not specifically aimed at the emergency department. It's more aimed at inpatient care settings, so do bear that in mind when you're reading the information. But hopefully a lot of the information will be relatable to you anyway. Whether you're just focusing on the ED or whether you're actually looking at your whole trust. And again, just make sure that when you're doing your risk assessments, you're kind of considering what's appropriate and needed for your local organisation, and then what also isn't applicable. So within these resources, so within the articles, I'll let you obviously look in your own time if you're interested. But we've got information on kind of benefits of self-administration. We've got guidance on implementing self-administration. So this includes things that we've talked about around risk assessments, recommendations to have a lead professional for self-administration at your organisation, and suggestions of how you can actually do individual personal risk assessments for self-administration. So i.e. for that person that you want to self-administer. Also, there's information there on responsibilities. So thinking about the different staff and different people that are involved, so including like carers and families and what their responsibilities might be, because you'll probably need to put that in your policies if you're writing policies or updating them. So that might be useful. And then there's a whole section as well on assessment and storage of medicines. So leading on from what Kunal was talking about around storage and safe storage, it's thinking about assessment of patient-owned drugs, controlled drugs, pod lockers. Also give some examples of potential exemptions from secure storage there as well. So hopefully that will be useful for you. And as I say, the URL there is at the bottom of the page, and we'll put it in the chat as well. Next slide, please, Lucas. So Parkinson's UK have also come up with some really good resources. So if you're not familiar with this, please also have a look because you might find it useful. Obviously, their focus is Parkinson's medication, but a lot of the themes and guidance can be extrapolated to other medicines as well. So do have a look at that. This one includes links to useful guidance, related resources, and there's also copies of organisations' policies that are actually available online there as well. So if you know where to start with your policy or you don't know what to write, there's some templates and examples there that you can use that might get you started. Next slide, please, Lucas. Oh, yeah, that one. Thank you. And then another reason why I'm here today is just to let you know, so I'm project lead for a programme that we're doing on safer use of time-critical medicines. So this is part of NHS England's Medicine Safety Improvement Programme. And our aim, similarly to kind of why everyone's here, is really just to kind of identify interventions that will reduce harm from time-critical medicines and share the learning and support people to replicate this across the NHS. Currently, we are recruiting for a national collaborative, so we're going to be working with some organisations to do local quality improvement projects. So from this, it's not the same work as the RCEM work, but obviously we're all aiming for the same end goal. We want to improve the safer use of time-critical medicines, and we will aim to publish our work. So please look out for that, because self-administration is an element of the work that we're doing. So if it's helpful to you all, that will be available publicly at some point. Next slide, please. Well, and I'll hand back to Jonny, I think, to lead the questions.
Yeah, so thanks very much. So it's very difficult in 45 minutes to crack the problem, but I hope that you find those three different parts of the presentation useful. I'll be very happy to open it up now to questions. Lucas, are you all right to allocate the questions, and then we can answer whoever we think is the most appropriate to.
No worries.
Thanks.
Everyone, of course, more than welcome to post your questions on the chat as well. But if you want to unmute yourself, more than welcome to do that as well.
We can maybe stop sharing the screen so we can see.
Yeah, I'll stop here, Jonny.
Real quick one, just whilst I've seen it. Michelina, I've seen you put a thing there. You're actually with us in Queens here. I reckon, so you've got a very specific issue there around the urgent treatment centre co-located. I feel like that would be a good thing for us to chat about directly, because that's a very, very specific problem. So that, I think that's something I might well approach you for, and we can chat specifically around that. But generally speaking,
not so much of a problem, but it's more of a, I know that there are some UTCs that are co-located with EDs, and since the project is being rolled out to EDs, I'm just thinking how we can join forces with the primary urgent care, because we also sometimes send those patients to you and vice versa. So it's about how we've got the flow of information in the right way.
So I think there's a big opportunity there around you being able to prompt for patients to be able to, particularly if you're sending them to ED, which is typically going to be it's potentially a long, more arduous process where there's lots of administration, lots of triage and all that sort of a thing. So in terms of communicating to patients around identifying they're on a time critical med and communicating that to ED and communicating that as a problem to your patients to say, by the way, have you thought about your time critical meds? Have you got them with you? If you haven't, and then this is a situation where you can't get them, please refer that to ED when you get over to there, then that's something that will help kickstart the process. So I think that's a really potentially valuable avenue for early identification to kick off the process. So I think that's a really good thing. I think probably more logical, we can chat really in specific detail around our local thing for that, but that's great.
So just while people are thinking, just to say, people in the year one of the QUIP, there was queries about how many people needed to be put on the transdermal patches. So, who had Parkinson's. So 80% of people who were in the QUIP with Parkinson's arrived by ambulance, and 80% got admitted. So there's only 20% of them going home. But less than 5% actually needed a patch because they were nil by mouth or their IV fluids. So 95% of these people with Parkinson's are taking their tablets orally. So it's I thought it would be more than that, but it actually wasn't. So there is scope, there is potentially scope to see out of that 95% how many can self-administer.
I think, yeah, off the back of that as well, Jonny, the other thing to mention off that, think about that HSIB case, so the case that Jonny mentioned earlier on around the Parkinson's patient who had a lot of doses omitted. They were written as being self-administering medications in the early part of their journey in the outpatient clinic. There then was some sort of an issue where they didn't self-administer. Now, we don't know that information, but consider that if you're removing medications because you have a safe custody policy, the risk benefit of that, removing Parkinson's tablets from a person who may be wanting to self-administer, not doing anything about it, that has a potentially detrimental effect. So that needs to be a risk assessment, particularly in the part I was talking around safe custody and removing medications from patients, thinking about the risk benefit of allowing them to maintain self-custody.
We could just bring everyone's attention here from the panel. Francisco, I see you have a hand up. Would you like to ask a question to the group here? I can see you have unmuted yourself, Francisco, but doesn't look like there's any audio coming through.
You hear me now?
Yep, working now. Perfect.
Yeah, brilliant. Thank you. So I was just saying, my name is Francisco. I'm a nurse practitioner by background and working in emergency departments. And I'm currently doing a PhD in self-administration of medicines, and quite interesting piece of work that you guys are developing. And I'm just wondering about the question that I put in the chat. So SAM is not a new concept, and the majority of NHS trusts have got a policy in place for this. And I was just wondering whether there's any reflections that you can share in terms of why this is not widely implemented. Bear in mind that trusts have got a policy for this.
I think the reason for that is that emergency departments in the past, it wasn't an issue because people moved from the department. The issue now is that people are spending a longer amount of time after they've been seen, waiting to go to the wards under one of the inpatient teams. So it's sort of become a problem within the emergency department now. People can have a discussion about whose responsibility the patient is. Is it when they get referred to medicine? Is it after 4 hours? Is it when they leave the ED? For me, it doesn't matter as long as somebody gives them their time critical medication, and that needs to be worked out locally. What we found in Leicester was the sooner we identify somebody's on a time critical medication, we think they're more likely to get it within half an hour. So we have a mandatory question at reception that says, are you on a time critical medication? Yes or no. If the answer is yes, then they have to go through the missed list and say which one it is. And we've gone from 65% of people being identified within 30 minutes to 99%. So they're now being identified that quickly. In the QUIP, it took about 38 minutes for a triage nurse on average to identify somebody who's on time critical medication. If you leave it to the clinician, it was taking nearly 3 hours, over 3 hours. So you've missed the boat then. And what we do is, from a Parkinson's point of view, if they're suitable, we get a triage nurse to speak to one of the prescribers to get all their medications prescribed, even if we don't know they're coming in or being discharged. because that way it's covered. And if they are coming in, then there's more of a streamline for the drugs to be given, and therefore somebody said in the chat, the ED doctors are reluctant to prescribe it because they're under the medics. Well, the point about it is, even if they are under the medics, it's still going to be the emergency department nurses that give it. So it's still going to be the ED team that gives the drug, even though it's being prescribed by the medical team. So it's really important to work out locally between your inpatient teams and your own EDs about whose responsibility it is, but it's really shared.
Yeah, just off the back of that as well, Jonny. So yeah, absolutely agree with Jonny. My experience also, so I was a patient experience fellow at my trust for a period of time. So I worked on self-administration. We looked at some of the barriers. As Jonny said, the two environments are completely different: ward-based and emergency care. So when they're on the ward, where you're starting to look at the assessment of self-administration, you typically have a diagnosis. You typically have a lot of information. You've been able to observe that patient over a period of time to really confirm capacity and the ability to self-care. You have a clear treatment regime around, and you've reconciled all of their drugs. So at that point, the risks around self-administration and how the ease of doing that is completely different than the risks and the issues related to emergency care. You don't have the ability that you've observed them for a period of time so you can determine capacity. You don't have a diagnosis. You haven't also always confirmed the drug history against the clinical presentation. Do you need to change anything? So typically from a risk aversion point of view, self-administration prior to clinical assessment typically doesn't fall within most trust self-administration policies within my experience. So because the ball game is completely different, the risks are completely different, you just don't see it uptaken as much. And we know people fluctuate, people have fluctuating capacity, even storage requirements. So the ability to access secure storage on the ward is not always that good. A cupboard with a key that can be locked, you can't give the key to the patient. Typically they can get into someone else's locker, so then you need bespoke areas. So self-administration on the ward is a whole nother process, but I think that's part of the reason why it's really not ED focused, and the challenges are completely different. Sounds like fabulous work you're doing, though. I feel like we should chat more.
I could just bring the attention here from the panel to the chat again. I can see there is a question here from Yasser, I believe, in regards to patients not often bringing the medications with them, and also the medications not always being available in the ED. Yasser was just asking how could this be addressed?
Yeah, I can feel that one. So the easy thing is make them available in your ED, add them to stock. They're not risky medications. So these aren't medications that are very expensive. They're not medications where you should worry massively about risks associated with prescribing inappropriately. So add them to stock. Another piece of work that we did with the Royal College was around standards for pharmacy services. So really all EDs should be having a clear designated pharmacy service. If you have that and you're in in compliance with the RCEM standards for that, the first thing you could do is very easily escalate that to your pharmacy team, your specialist clinical pharmacy team. They can pluck whatever Parkinson's meds that you think are appropriate into the appropriate areas, and you'll have them available. Obviously, that's not going to be self-administration. That's more of your traditional prescribing administration. But there's very little reason not to have Parkinson's medications available in ED as stock. They're very low risk. They're not expensive. So I guess the first thing is review your stock list. Make sure you've got easy access to time-critical meds, in particular where they're low-risk time-critical meds around these contraindication situations.
Thank you, Kunal. Just moving to another question here for yourself and Jonny as well. I can see Sinead said on the chat that the local team is establishing an MDT working group, and the drugs and therapeutics team initial concerns from the initiative on capacity as well as safe storage. And Sinead was just wondering if there's any success stories that could be shared where meds are not taken off the patients. And also for yourself, Jonny and Kunal, what do you do in your own trusts about this?
So I can partially answer that one. So there shouldn't really be any concerns around capacity because there should be an assessment done as part of this, which will deem whether the person has the capacity to take their drugs or not. So that shouldn't be a concern because it should be done. Safe storage is the difficult one, I think. I mean, our nurses in the ED have always taken a common sense approach to this, and we've always allowed patients who the nurses themselves deem to be suitable to take their medication. It's never been formally documented, and what this does is it's hopefully good for the patients, but it also will open a lot of can of worms and formalize the process. So we need to convince the trust that if I walked in an ED and had my medications in my pocket, is that safe storage? Well, I think it is because they're my meds and I have them in my pocket. I'm not going to potentially put them anywhere. But I mean, it's going to be different for different people. But I think it goes back to the point of patients should be able to show their medications. They should have the capacity to have that conversation with the team. And I think you need to have that in front of your mind when you're actually trying to describe the patient who can self-administer. So, anybody who can show their meds, who can walk in and has gone to a minor injury area or an ambulatory area, that it's that concept of like being in an outpatient. In Leicester, all our day cases are now can self-administer all their time critical medication. It's kept on them. They just take them normally as they would at home, and it's that sort of concept that we're trying to bring in for those patients that are barn door, no problem. It's the ones that come in that potentially they're not going to fulfill the show assess criteria, and therefore it needs aided. So as I said, we're not going to hit 60% by any means, but it's got it up to 25 or so. That would make a big difference.
Yeah, we just very much echo what Jonny said as well. It's about a dynamic risk assessment and being sensible. I guess what I would say is, in terms of your drugs and therapeutics concerns around capacity and safe storage, that always needs to be balanced with if you do remove the medications from someone, what the potential damage is done there as well. So it's really understanding, we have 80, 90 people in our waiting room waiting to be assessed. Now, if you're arguing that you can't confirm capacity or you're worried about capacity, should you be removing all medications from those patients in the waiting area? How are you going to work out getting them back to them? And are you going to cause a problem getting back to them afterwards? So you have to be pragmatic around the areas that you're targeting. The completely different story for a resus area. Maybe those people should not be maintaining possession of their medications. You've got a relatively small number, you can control it. If you're arguing in an ambulatory area with a lot of patients, how are you going to be able to realistically do that? Should you be targeting specifically patients who have capacity issues or mental health problems or overdose type risks? So the piece of advice I'd give you is your drugs and therapeutic committee really understanding the risk of what you're doing by taking tablets off people as well. I think that's something that's massively underappreciated, under-considered.
I think it's going back to that first slide of, if you say to your drugs and therapeutics committee, if an 85-year-old man walked into our department today, self-administered his first dose, and would he, if he had to wait, 52 hours to go to the ward, are we happy sitting here around this table that he would get all 18 of his doses? And if the answer to that question is yes, well, that's great. You don't need to do anything. But if the answer to that question is no, then you need to look at the reasons potentially why and what might help. And self-administration maybe one of those things that help. And Kunal's right, and you can't take your self-administration medicines policy for the wards and use it in the ED. It doesn't work. It's a different way of thinking, and it's a different concept in a sense. So they need to understand that and come up with a compromise that will allow. I mean, there's no problem taking medications off people. No problem with that, as long as you give them back to them, give them when they need them. That's not a problem, but that's not happening on a regular basis across the country.
Thank you, Jonny and Kunal. Just so that everyone know, I think we're past now the end of the event, so perhaps we could just take the final questions on the chat. I see Francisco, you have your hand up as well.
Yeah, it's more of a statement rather than a question. I totally agree with what Jonny was saying, and I think we sort of complicate, the issue of self-administration of medicines in hospital a little bit too much. The truth of the fact is that these patients are taking their own medicines at home. Why do we stop them from taking their medicines once they arrive to ED or any other setting? I obviously understand and take on board the concerns around risk and their own capacity, whether they are confused or whether they've got any sort of cognitive impairment. But those patients are easily identified once they get into hospital. So I think I wonder whether there's something around a new vision and a new way that we can make this work rather than approaching these from a sort of a more targeted direction, because I think it's more about how the system altogether works around self-administration.
I tend to agree with you. I don't have anything to add to that. And I think that's something maybe we should chat about in future around full systems approaches for that. Obviously, the purpose of this webinar is more specifically related to emergency departments, but I don't disagree with you. I think it is overcomplicated. And I think the risks haven't really been thought through, particularly in modern medicine and modern secondary care as well.
Yeah, Francisco, if you can show assess, aid, allow, and monitor works, that would be brilliant.
Yeah, I'm happy to share any findings, but I'm on the very early stages of my work, but happy to be in touch.
Lovely, thanks.
Sounds good. I think Santosh, see your hand up as well.
Thanks, Jonny. This is just my comment. How emergency department ambulatory area, which is a waiting walking patient, how is it different than an airport where the patient or the customer wait for 5-6 hours? How is it different for their own? Because they take their own medicine when they are waiting for the flight to catch or any other travel accommodations. This is just my observation. We as a healthcare professional are too much. We want to take control of patients' independence. So when they come to hospital, we want to be the only controller of all of their health condition. I think if we let them decide, I agree, there is a second cohort of patients who are more confused, Parkinson's medicine, who cannot communicate well, and who come by ambulance. They may not have their own medicines, but the cohort of patients who walk in, and we know that they can wait, and probably it's from a triage point of view, because there are more acute patients happening in the major or research area, they will be the walking patients will be the one who is more safer to wait for more than 4 hours. So this is just my comment. If we are allowing rest of the other population to wait in airport or wherever for 4 and 5 hours and they take their own medicine, why we need to have a policy for the similar cohort of patient in emergency department where they walk in fully compass mentis. The only caveat to that is the mental health patient who come in by overdose.
Yeah, I mean, I think what will happen, I mean, I think what will happen is that as this progresses, I think what will happen is people that walk in, I think this happens in our department, except we don't necessarily document it. I think people that sit in the waiting room should be able to self-administer their own time-critical medication, unless there's a major, a head injury who's on warfarin or something. But, after speaking initially to the reception and the desk, I think what will happen is that people who are waiting, who are ambulatory, who aren't, in the main sort of resus or majors, probably will be able to self-administer their time critical medication. I mean, one in five Parkinson's patients is under 60, so that's 20% already. Now, there's going to be very few contraindications for those 20% of people not to take their own medications, unless they're by mouth or they're on IV fluids. But yes, I agree. And the concept of an airport waiting room for the wards is this. Time critical medication is priority boarding. That's it. That's the bottom line. So, the time critical medication patients should be priority boarded on the plane. Everybody else, it gets standard seats. It doesn't matter whether you're in 7A or, 25B or, whatever, where you are in the ward. Patients with time critical medication should be boarded as a priority and get their medications priority. And that's why, drug rounds need to change, and self-administration is part of that, because you're basically getting them on the plane. They're getting on the plane themselves.
Thank you, Johnny. Believe it or not, almost 10 minutes past the end. So would it be all right if everyone could just end the session here? Right, perfect. So just to let everyone know, the recording of this session will be made available on the quality improvement page of the website, and you're more than free to go there and share once it's uploaded. We'll have it as a YouTube video, so should be very easy to share. Thank you everyone for attending and taking your time this afternoon. A special thank, of course, to the panelists here, Jonny, Jen, and Kunal, for the excellent job in preparing this presentation and delivering all this great knowledge to you all here today. All right, I'm gonna end the meeting here. Nice to see everyone. Take care. Enjoy the rest of your day.
Thank you.